Hi, hello everyone. So I'll start again. कुछ questions हैं जहाँ पर I'll just take the doubts and then start. So isn't stress a kind of injury to the cell? Literally तो injury है, but not exactly injury है. मतलब आप खुद example सोचो ना. मैंने example what did I example give you? I gave you an example of your MBA exam. Is MBA exam an injury to you? No, it's a stress. Let's call it a stress only. Yes. अगर if MBA exam continues every day, then it's a injury obviously. ठीक है ना. तो duration is very important for a stress converting to a injury. uh, Atrophy is a type of cellular adaptation, but cell death occurs during this also. नहीं बेटा, देखो atrophy is a condition where the cell number decreases. After this event, sometimes a cell death can occur by autophagy, but that depends upon how is the body responding to it. If the body feels that the organ has atrophied to such a extent that it has extended to such an extent that it is not needed, then there will be cell death, else not. ठीक है, else there is no need. Okay, चलो. तो now we'll take the next topic, and the next topic we'll take now is about the irreversible injury. Okay, irreversible injury. The next topic we're going to discuss is the irreversible injury. In the irreversible injury, there are two of those: A, necrosis, and B, apoptosis. ठीक है. Let's start with the topic of necrosis and then we'll move to the topic of apoptosis. Okay, let's start with the topic of necrosis. देखो, again try to take a full page for it. Necrosis basically it is due to it occurs due to severe oblique persistent, okay, severe or persistent ischemia. Again I repeat, most of the physical injuries, most of the chemical injury, free radical injuries, all of them ultimately leads to ischemia. Okay, the severe and the persistent ischemia, this causes severe and persistent hypoxia. It causes severe and persistent hypoxia. The moment this happens, it leads to what? It leads to the ATP depletion. Okay, it causes ATP depletion. Now see, in the reversible injury, what was there? It was a happening of ATP decreasing. Here, however, there's ATP depletion happening. Okay, this ATP depletion, it causes sodium potassium ATPase pump to stop. Okay, the pump now completely stops. Now this is important. The pump will stop here. There it had decreased functioning. It now has completely stopped. Now, once it stops, what are the effects going on? See, one of the effect is the same thing. Suppose this is a cell and this is a pump putting sodium out, taking potassium in with the help of ATP. Okay? So what happens? The ATP is no longer there. Because the ATP is no longer there, what happens? There occurs increase in the sodium in the cell. Okay, at the same time the potassium level decreases, right? But remember one thing, in physiology you might have read there's one more pump in a cell. It is called as calcium efflux pump, which also acts by the ATP. There's one more pump here by which the calcium efflux occurs. Okay, and calcium efflux pump also depends upon the ATP. So what happens, because this pump is also not functioning because of the reduction in the or absence of ATP, this also increase in calcium in the cell. Now what is important to understand is this injury has definitely increase in sodium, no doubt about it. Decrease in potassium, no doubt about it. That means the initial change will occur just like reversible injury because there also increased sodium had occurred. Here what will happen, because of the increase in calcium now, the calcium becomes the main factor causing irreversible injury. So what is common between reversible and irreversible is sodium. But what is different here is increase in calcium. The bigger question is, sir, will calcium not increase in the reversible injury? It will increase. But it won't increase to that extent because the ATP is not depleted, it has reduced there. That means, let's come back to the topic of reversible injury here and just right here, increase in calcium will slightly occur in the cell. Now this is important, just mention it here. Increased calcium occurs in reversible injury also. But when we move to the irreversible injury, this increase in calcium is to a very, very high extent. Let's write it here now. There's huge increase in the calcium here, which becomes the main factor for irreversible injury. So this causes increase in the intracellular calcium. No doubt there is definitely increase in sodium. Definitely there is increase in sodium also, but this is the main factor. This is the main factor occurring in this type of injury. It's the main factor occurring here. Okay? It's the main factor. Now, first of all, I told you every time there's a EM change, and that EM change occurring here is due to increase in calcium. The increase in calcium, what it does is the increased calcium looks as in the EM on the microscopy, they look as large amorphous densities. Okay, this mostly occurs in the mitochondria. So this also means in bracket, right, in reversible injury you will definitely see small amorphous densities. You'll surely see small amorphous density, obviously in the mitochondria, because in reversible also there was increase in calcium, but here it is large amorphous density, which makes a good amount of changes morphologically to identify reversible versus irreversible. That means, in fact, whenever you see a term large flocculent amorphous densities, this term flocculent means large. It actually is seen in irreversible injury only. But there has been an MCQ in the NEET pattern asking you small amorphous densities, then the answer is reversible injury. Anyhow, the other effect of increase in calcium, you all know calcium is the cofactor of enzymes. It's a cofactor of enzymes, and therefore the calcium being a cofactor of the enzymes, the calcium, it basically activates the enzymes. The calcium basically activates the enzyme in a cell. And which enzyme do they activate? Which enzyme do they activate? There are 4 of them. Remember, there are 4 enzymes which a calcium can activate. A simple mnemonic is A, P, E. Among this A, there are 2 P and there is 1 E. Let's see how. A is ATPase, P is protease, next P is phospholipase, and E is endonuclease. E is endonuclease. So the enzyme have a simple mnemonic APE. There's 1A, ATPase, protease, phospholipase, and there is endonuclease. What do these enzymes do? See, ATPase will virtually deplete the ATP. See, ATP is already depleted. Now, any new ATP getting produced will now be destroyed by the ATPase. That means ATP depletion is aggravated, and because of this, the change will become more and more severe. It will be self-aggravating situation. Okay, the protease and phospholipase. What does this do? Sorry, the protease and phospholipase. What they do is the action of phospholipase. What it does is the phospholipase is basically in the plasma membrane, and proteins are also an integral part of plasma membrane. I hope you all know this, that the bilayer model, okay, the bilayer model of plasma membrane, it tells you that there is a lipid which goes up and down, vertical movement, and protein which go in the lateral movement. It goes in the lateral movement. Okay, it goes in lateral movement. So basically what is happening there is the protease and the phospholipase, both of them together, it will lead to the plasma membrane damage. Both of them will lead to the plasma membrane damage. They will lead to the plasma membrane damage. Okay, the endonuclease will lead to the chromatin damage. They will lead to chromatin damage. I'll tell you how does it happen, but first of all understand the plasma membrane has got damaged and how will it affect. See, not only the plasma membrane, it will also damage the lysosomal membrane. Damage will also occur. So two things are getting damaged. One is the plasma membrane damage and one is the lysosomal membrane damage. Now the problem is, once the lysosomes which have acidic enzymes inside it, this gets damaged here, all the enzymes are coming out. All those acidic enzymes like the carbohydrases, proteases, phospholipases, all these are again coming out. And these enzymes are together called as hydrolytic enzymes. So what happens, there is release of hydrolytic enzymes. The release of hydrolytic enzymes. These hydrolytic enzymes, this will lead to tissue damage. So all around those cells which are getting damaged by the action of phospholipase, the tissue damage starts occurring. Remember a rule of pathology. Whenever a tissue damage is occurring, those damaged tissues have been has to be removed by our inflammatory cells, which initially are neutrophils and later on becomes macrophage. So what initially comes out there is neutrophil. So this tissue damage are removed by neutrophil. It causes neutrophil infiltration. It causes neutrophil infiltration. And this is referred to as, in bracket write, acute inflammation. It's referred to as acute inflammation. So let's understand this again. Because of the protease and phospholipase action, the plasma membrane has got damaged of a cell, and inside that the lysosomal membrane has also got damaged. From the lysosomes, the hydrolytic enzyme has come out and damaged the entire tissue around it. That tissue damage will cause neutrophil infiltration. It is called as acute inflammation. So acute inflammation is an integral part of irreversible injury, that is necrosis. Okay, irreversible injury, that is necrosis. Okay. Now comes the endonuclease action. The endonuclease action causes chromatin damage. The three morphological types how this damage can occur. The three forms, okay, three morphological forms how this damage can occur. First of all, there can be A, condensation of the nucleus. This condensation is often called as pycnosis. B, it can lead to fragmentation called as caryor, K-A-R-Y-O-R, carrier, R-E-X-I-S, fragmentation. And C, there is complete dissolution called as karyolysis. So any of these forms can occur. It can start with pycnosis, then karyorexis, and may lead to karyolysis again. So three things again, mention it: pycnosis, karyorexis, and karyolysis. Okay, pycnosis, karyorexis, and karyolysis. Now see the end effect. Dekho, what is happening is, because of the protein damage, okay, because of the protein damage, what is happening, this protease action, this one, okay, this protease action, the protease action, that is damaging the protein. And remember a basic rule again: the damaged proteins always stains pink in color. The damaged protein always stains pink in color. Damaged protein always stains pink in color. So the action of protease, which is damaging the protein, damages protein, and this stains pink. It stains pink. The pink staining of a cell is often referred to as increased eosinophilia. Is referred to as increased eosinophilia. Okay, it is referred to as increased eosinophilia. And remember one thing: because of the karyolysis, the blue color of a cell will decrease, and this is referred to as decreased basophilia. So now you see the two things to understand here: increased eosinophilia, more pink color; decreased basophilia, less of blue color. Again I repeat: increased eosinophilia, decreased basophilia. Well, I again repeat this before we move further on. What are the enzymes getting activated? There is ATPase, there is protease, there is phospholipase, and there is endonuclease. ATPase depletes the ATP. Protease and the phospholipase will damage first of all the plasma membrane and then will also damage the lysosomal membrane, because of which there is release of the enzymes causing tissue damage around it. All those damaged tissues are removed by neutrophils, and hence we call it acute inflammation. Endonuclease action, it causes chromatin damage. It first causes pycnosis, then fragmentation called as rhexis, and final dissolution called as carolysis. The end effect is more pink color, less of blue color. More pink color, less of blue color. Now, what are the electron microscopic changes? What are the EM changes? One of them I have already told you above. Large flocculent amorphous density in the mitochondria. Okay, large flocculent amorphous densities in the mitochondria. Second is there is something called as myelin figures. Now what are these? Actually what happens, all the phospholipid on membrane, PL means phospholipid, on membrane, after getting acted by phospholipases, they make phospholipid disintegrated products. They're called as myelin figures. So what happens, suppose this is a vacuole. Inside the vacuole, you will see there are the proteins like this. These are the myelin figures. They actually are laminated deposits of damaged phospholipids. They are called as myelin figures. Okay, myelin figures are seen on electron microscopy. What are these? They are phospholipid disintegrated products. They are seen on electron microscopy. Now we'll see what happens on the light microscope. What are the light microscopic changes? Again, very, very important. See, let's assume I'm making the few hepatocytes like this. These are all the hepatocytes as they're arranged like a cord like this. They all have this blue color nucleus, as you all know this, normal blue color nucleus. And if you see, they all will have the light pinkish cytoplasm like this, right? They all have this light pinkish cytoplasm in this manner. This is how the normal hepatocytes look like. The normal hepatocytes are like, these are normal hepatocytes. Now see what will happen. If this hepatocytes undergoes a morphological cell death of necrosis, if this undergoes necrosis, what will happen? To remember this, first of all, remember there are two morphological types of necrosis. One of them is coagulative and one of them is liquefactive. One of them is coagulative and one of them is liquefactive. For now, just understand the coagulative first. Okay? And we'll understand this on the basis of conceptual understanding we have just seen above. What all have we seen above is, if you look at the light microscopic changes, the finding you expect there is, just see this, more of pink color, less of blue color. Second, acute inflammation. Second is acute inflammation. Okay? Third is plasma membrane has got damaged and nucleus is damaged. Let's draw these four things in this diagram. Let's see what would you expect there. First of all, the plasma membrane of a cell should be damaged. So what I'm doing is I'm drawing a damaged membrane like this. Understand, even though I'm damaging the membrane, still the outline is still remaining intact. Why? The reason is, all of these damaged tissue has to be removed by the enzymes. Okay? They have to be removed by enzymes, but even enzymes and the cells. But even before that occurs, why is this getting damaged? Because of the phospholipase action. But at the same time, please understand that this is a irreversible injury where the ATP is drastically reducing. And just like the reversible injury, there's also increase in the lactic acid. Remember? Now see, increased lactic acid will decrease the pH, and the decreased pH will inactivate the enzymes acting on the cell. That means initially when the damage occurred, all the cell membranes have got broken. But to dissolve this completely, you still need the active enzymes. But what happens whenever the decrease in pH is happening, the decreased pH will inactivate the enzymes. The decreased pH will inactivate the hydrolytic enzymes of the lysosomes. So what happens because the decreased pH, please understand this, decreased pH, it will inactivate hydrolytic enzymes, and so what will happen after the damage of the plasma membrane? It is not completely dissolved. That is the reason that because of the inactivation of the lysosomal enzymes, the cell outline is maintained. Okay, and this maintained cell outline is only for a few days. After a few days, when the lysosomal enzymes will again reactivate after the pH gets stabilized, again the entire this outline is completely dissolved later on. But initially, to some extent, to 1 to 2 days, the outline may still be there. Such maintained outline is there. What else should you see? Apart from this, you should be able to see the neutrophils. Let's assume these are neutrophils like this. Okay, the neutrophils here. These all are the neutrophils you expect in and around the cell. Neutrophils you expect in and around the cell. Okay? And then inside this, you see the pink, more pinkish cytoplasm, because I told you, you won't find any nucleus, but what you will find is, you won't find any nucleus, but what you will find here is actually what? Bolo? Neutrophils and inflammation. You won't find any nucleus, but more and more pink color. What is important and striking to note in this diagram is the outline is maintained. Because of the maintained outline, such findings are referred to as, morphological findings are referred to as tombstone appearance. Tombstone appearance. They are referred to as tombstone appearance. Okay? Tombstone appearance. Okay? They're also called as, sorry, moth-eaten appearance. Okay? Now see, these are neutrophils. These are neutrophils here. Tombstone appearance or the moth-eaten appearance. Remember, the morphological finding is cell outline is maintained. This line is very important. The cell outline is maintained. Okay. The big question is, sir, where do we see this? Basically, ischemia to all solid organs. Ischemia to all solid organs. The only exception here is central nervous system, brain. I'll tell you why, but later on. First, write ischemia to all solid organs except the brain. Second cause is not only ischemia, this was ischemia, it can also be due to thermal injuries. Can also be seen in thermal injuries. It may be seen in a necrosis of the muscle called as Zenker's degeneration. Now, what is this Zenker degeneration, guys? Zenker degeneration is a condition where you see necrosis to rectus abdominis muscle seen in typhoid fever. Necrosis to rectus abdominis muscle seen in typhoid fever. It's seen in typhoid fever. Okay. Necrosis to rectus abdominis muscle is seen in typhoid fever. Okay. So tombstone appearance, moth eaten appearance seen in ischemia to all solid organs except the brain. Now, this is the one type of necrosis. Clear? Let's assume, let's assume that this necrosis has remained for a long time. 2 days have happened. After 2 days, the enzymes have now reactivated, and now these outlines are completely liquefied. When the outlines are completely liquefied, it causes something called as liquefactive necrosis. It causes something called as liquefactive necrosis. The question is, where else do you see liquefactive necrosis? The answer, देखो. First tell me, why was the cell outline maintained here? The answer is decreased pH, inactivates enzyme, and therefore these outlines are there. Suppose outline are there, right? The outline is still there because all the cell membranes have a small amount also of collagen. The inner part of the membrane, they have structural framework of collagen. Okay, there are some organs, however, who do not have the structural framework of the collagen. For example, the CNS, the brain and spinal cord, they have myelin. The fats. Therefore, they don't have the collagen. So even though in brain also there's decrease in pH, in activating enzymes, still because the brain don't have the collagen framework, that outline is also not maintained. And eventually the brain on the day 1 causes liquefactive necrosis. So what happens in liquefactive necrosis is, because of the absence of the structural framework of the collagen, the entire tissue liquefies like this essay. Complete liquefaction occurs without any outline like this. No outline, everything is completely liquefied essay. No outline at all. So here you don't see any outline, no outline, no outline. Reason is because it's seen example, ischemia to central nervous system. Why? Because they have myelin. They have myelin. That means there is very high fat content and very low collagen or protein. Very low collagen or protein, and therefore very low collagen and very low protein, and therefore it is not able to even maintain the simple outline, and everything liquefies. Definitely you will expect the neutrophils. In fact, after 2 to 3 days, it will replace the macrophages to remove out the entire debris. Okay, after 2 to 3 days, you'll find the macrophages to remove the entire debris. So first example is ischemia to the central nervous system, that is the brain and the spinal canal. This brain and the spinal canal. Okay. Second is a qualitative necrosis along with the bacterial infections. Now this is very interesting again. You see, the body enzyme of lysosomal enzymes, the body lysosomal enzymes were inactivated. Agreed? Because of which the cell outline could not be maintained. However, if the bacteria infection occurs, and if the bacteria releases proteolytic enzymes, if the bacteria releases the proteolytic enzymes, and this will dissolve the outline. This may dissolve the outline. This may dissolve the outline. Because this may dissolve the outline, if this will dissolve the outline, again will cause what? It will cause liquefactive necrosis. That means any superimposed bacteria infection over a qualitative necrosis will lead to liquefactive necrosis, will lead to liquefactive necrosis. Now ultimately, if you look at the morphology, agreed, this is a complete liquefied tissue. This liquefied tissue is referred to as pus. So what is pus? Pus is nothing but a liquefied tissue along with neutrophils. Okay? It is called as pus. Highlighting it below. What is pus? These two things are clear. These two things are clear. Coagulative versus liquefactive. Okay. Now write it down below. What is a pus? देखो, pus is liquefied necrosed tissue along with neutrophils. Okay, it's a liquefied necrosed tissue along with the neutrophils. So pus is a finding of liquefactive necrosis. And remember, pus in a localized space is called as abscess. So often an organ showing pus will be called as abscess. What is abscess? A localized collection of pus. Localized collection of pus is called as abscess. Localized collection of pus is called as abscess. Similarly, so if you talk about the necrosis type, the first one was coagulative. Let's call this A. Next one is B, liquefactive. It is also liquefactive is also called as coagulative. The other name for liquefactive is coagulative. The other name for liquefactive is coagulative necrosis. Okay. Now, one more type is the third type here is gangrene. Okay. Remember, gangrene is not a type of necrosis. Gangrene basically, the word gangrene refers to, it's a clinical term. It's a clinical term. Okay. Now, the basic thing to understand is how will gangrene occur? How will gangrene occur? Dekho. Basically, you talk about the gangrenes here. You talk about the gangrene. What and how does the mechanism of gangrene occur? Dekho, very easy. Suppose this is a foot of a patient. Okay. And there's a blood supply here. Okay. There's a blood supply here. Okay. Now, let's assume due to any reason there is a blockage of blood supply at this position. Maybe because of the atherosclerosis, it can occur. It can occur because of some type of vasculitis. Like in vasculitis, we'll talk about the Bartter syndrome, or it can be due to atherosclerosis. It often happens mostly in the patients who are smokers. Okay. Now see, because of this area of the tissue, this becomes ischemia. Because of the complete ischemia here, because of complete ischemia here, this ischemia, because of complete ischemia here, this level of ischemia will cause what? This level of ischemia, what does it cause? It causes, ischemia will cause necrosis. And which type, guys? Coagulative necrosis. Okay? Once it causes coagulative necrosis, again the same thing will happen. This area should be infiltrated with the neutrophils. But remember, neutrophil will reach here by vessels only. The problem is vessel is completely blocked. So even the neutrophils cannot reach this area. Ultimately, this area is devoid of neutrophils and devoid of oxygen. The area has no other choice other than to undergo what? Anaerobic decomposition. It undergoes anaerobic decomposition. Anaerobic decomposition. Okay, anaerobic decomposition. It causes anaerobic decomposition. Okay, this anaerobic decomposition, what does it show? Anaerobic decomposition, what does it show? It shows black color and offensive smell. Black color plus offensive smell. And this entire tissue here becomes completely black acid. Becomes completely black. This type of necrosis is called as coagulative necrosis. And this type of gangrene is referred to as dry gangrene. It's called as dry gangrene. Secondly, there's something called as wet gangrene also. There's something called as wet gangrene also. So over the dry gangrene, if there is a superimposed bacterial infection, again the same thing will happen. The necrosed tissue will now be removed by neutrophils, and that becomes what? Liquefactive necrosis. So if ever you find a dry gangrene, dry gangrene with a superimposed bacterial infection will lead to liquefactive necrosis. In other terms, this will be actually called as wet gangrene. So remember, whenever you see a dry gangrene with a superimposed bacterial infection, it is called as wet gangrene. It's called as wet gangrene. Okay, it's called as wet gangrene. Let's see some images to understand this better, and then we'll see the other findings. Therefore, look at this image first. Now, what you're seeing in this image is, this is the image of a kidney, and this kidney shows a wedge-shaped infarct. So this is a white area. This white area represents the infarct. What is it, guys? It's a infarct. Now, what is infarct? By definition, infarct is a localized area of necrosis. Which is necrosis? Ischemic necrosis. There are various types of necrosis. It's ischemic necrosis. Localized area of ischemic necrosis is called as infarct. Now, as it's looking white, so often we'll use the word white infarct for this. It's called as white infarct. It's called as white infarct. Okay? Now look here. This is a histopathology of the kidney. It's a histopathology of the kidney. Now, before you see that, let's look at the normal histology of the kidney. Okay, in the normal histology, because this whole thing, this is the glomerulus. Okay, this whole big thing is a glomerulus. Okay, and these are all the proximal tubules. These all other tubules. Okay, now look at the tubules, outer and the inner membrane of tubules, and this round thing is a nucleus. These all round things are nucleus here. These all round things are nucleus here. Okay. Okay. Now look at these tubules. Look at this nucleus. The nucleus here. Now when you look at this, देखो यहाँ पर. What is happening is, this is a glomerulus. Okay, and look at these. What are these? These are all the Necros tubules. What is very interesting to see here is, if you look at these tubules, you'll all appreciate that they don't have the nucleus in the walls, right? They don't have nucleus. What is very interesting to note here is, they don't have the nucleus agreed. But look at the outline. They have this preserved outline like a ghost. Tombstone appearance. The preserved outline like this. Look at the preserved outline here. And these all blue cells are what? These blue cells are all the neutrophils infiltrating there. That's called as acute inflammation. So the increase in pink color, so increase eosinophilia. No nucleus, decrease basophilia. Look at the inflammatory cells here, neutrophils. And look at the preserved outline that you see here. It is called as coagulative necrosis. So simple. But believe me, when you read this in your medical college, nothing will go to your mind, because nobody will teach you like this. And if you don't believe me, attend the class of necrosis. You will believe me what I'm trying to say and what do they try to say. It is necrosis. So this is coagulative necrosis. Now look at this image and tell me, what do you think are these? Again, it's a heart muscle. If you look at this part above, again this part is appearing completely pink. But again you see the outline is well maintained. And hence in the heart again, because heart is a solid organ, again it's a type of coagulative necrosis. Look at the outline being preserved, look at the pink color, no nucleus, and hence it is coagulative necrosis. If this is coagulative, let's see the next image, this one. Well, this is the brain, okay, it's a brain, and this is the necrosis here. This brain has a ischemia or the pus here. So when I take a biopsy from this part, it shows something like this. Look at the entire tissue here. The entire tissue is completely liquefied. Do you see any cell outline? No. The complete tissue here is completely pink in color. This whole pinkish area is called as pus formation, which signifies liquefactive necrosis. What is happening here? This area is showing you macrophages infiltration. The macrophages is engulfing the dead tissue. So ultimately, if you take a biopsy of this after 5-6 days, the entire necrosed tissue will be completely removed by the macrophage, because that is what a macrophage is supposed to do. A macrophage is supposed to remove all the dead tissue, because macrophage is what? It has a scavenging action. Scavenger क्या होता है? Dead tissue को engulf करके हटाना. That is what a macrophage is supposed to do. So this is a example of liquefactive necrosis. ठीक है? Again see. Coagulative, क्यों? Cell outline preserved. Coagulative, क्यों? Cell outline preserved. Now look at this image, beautifully preserved cell outline. Look at this image and compare this image to your seeing here. ये देखो. Do you see any outline anywhere? कोई outline दिख रहा है? Completely pink. देखो, completely pink area with huge neutrophils infiltration, and hence it is liquefactive necrosis. ठीक है? Now look at this image. Dry gangrene and the wet gangrene. Very simple to understand. Wet gangrene has a dry gangrene with a superimposed bacterial infection. Dry gangrene has just a gangrene. It's a dry. It is offensive. It's black. But when that has a superimposed bacterial infection, it is wet gangrene. It is wet gangrene. Okay? It's a dry gangrene and it's a wet gangrene. This is coagulative necrosis. This is liquefactive necrosis. Okay? Let's move to the other types of necrosis now. So till now we have read coagulative, liquefactive, and one type of clinical term that is called as gangrene. Let's move ahead now. Third type हो गया. Fourth. The fourth type of necrosis is often called as caseous necrosis. Caseous necrosis. Again, why do we use the word caseous? Just like in a gangrene, the entire tissue had become basically black. In caseous, the tissue becomes white, and white like a cheese. Remember, it's a necrosis where you see in the gross morphology, you see white, cheesy, cheese-like deposits. Okay, it shows white, cheese-like deposits. Example, tuberculosis, syphilis, and histoplasma. ठीक है? And histoplasma. White cheese-like deposits like TB, syphilis, and histoplasma. Now, this necrosis morphologically in the microscopy, you'll often see a coagulative necrosis, but may show you liquefactive necrosis as well. But this will always be seen with granuloma. Now, what is a granuloma? This I'll talk about in the next class, in the next topic, next videos that will be coming up of inflammation. That's a different thing. So don't worry about it. That's right. It usually shows granuloma formation. Example is TB, syphilis, and histoplasma. Let's see how does a caseous necrosis look like. Dekho. This is a lung morphology. Okay, it's a lung morphology. This lung has a white cheese-like deposit, this white area. When you take a biopsy from here, it shows this type of necrosis. In this image, you are seeing this area has a liquefied necrosis. Look at these blue neutrophils here, and this is a giant cell. Okay, this is a giant cell. It's a multinucleate cell. Dekh rahe ho? Multinucleate cell. One cell has many nucleus. It's a giant cell. So when you see a giant cell in a collection of the inflammation, it becomes a granuloma. We'll talk about granuloma separately also, but right now remember, whenever you see white cheese-like deposit, look at this lung again with a localized white cheese deposits, or a lung showing widespread completely. You see complete area showing you white deposits here. These all are types of caseous necrosis. It's a type of caseous necrosis. So I again tell you, the word caseous refers to white cheese-like deposits. White cheese-like deposits. This caseous. The fifth one is actually fatty necrosis. Fifth one is fatty necrosis. That means it means necrosis to the fat cells. It is necrosis of fat cells. That is adipocytes. So when will the necrosis of the fat cell occur? In two reasons. in two regions. One of them can be enzyme, so I'm writing it enzymatic necrosis, and one of them can be trauma, I'm writing it traumatic necrosis. Let's see how. Suppose a patient has a condition called as acute pancreatitis. That means there is an inflammation of the pancreas. Now, I hope you all will remember the first year that pancreas has various enzymes. They have the proenzymes like the carboxypeptidase. They have the various enzymes like they have the carboxypeptidase. They have the procollagenase. They have proelastase. They have chymotrypsinogen. So all the zymogens, okay, they are the zymogens. Now, because they are the zymogens, what happens that whenever there is an activation of the pancreas, what happens? The pancreas will release all the enzymes. Okay, so what happens? The enzymes, the hydrolytic proteolytic enzymes, the proteolytic enzymes, and the lipases, they all are released. Because these all enzymes are released, the proteolytic enzyme will cause tissue necrosis, okay, and the lipase will break all the triglycerides to form free fatty acids. The triglycerides are what? These are the adipocytes. So adipocytes having the triglycerides will be broken down and will form what? Free fatty acids. It has been seen that the free fatty acids can combine with the calcium, and these two things leads to chalky white deposits. They cause chalky white deposits. So in acute pancreatitis, all the pancreatic proenzymes are released out actively. Those enzymes which are proteolytic will damage the tissues, and some enzymes will damage the adipocytes, will start damaging all the adipocytes of the, I'll say, the tissue around them. For example, they will damage the adipocytes of the mesenteries or the retroperitoneum. So all of those adipocytes will start getting damaged. Once they're damaged, what comes out is free fatty acids. The free fatty acids can combine with the tissue calcium to form chalky white deposits. Now this is a significant feature. The chalky white deposits on the mesenteries or retroperitoneum is a good indicator that the patient may have acute pancreatitis. This process is called as saponification. The process is referred to as saponification. Now see here the traumatic. This is traumatic. What happens in the traumatic necrosis is, what happens? In traumatic necrosis, there is trauma to the fat containing tissue, the fatty tissues. Trauma to the fatty tissues. So those tissues which have huge amount of fat is destroyed or damaged with the trauma. Example, breast tissue. Okay, breast tissue. Now, trauma to the fatty tissues, it may include the breast or the buttocks or the abdomen. Okay, trauma will include the breast, buttocks or the abdomen. Okay, breast, buttock or the abdomen. Breast, buttock or the abdomen. ठीक है? Breast, buttock or the abdomen. Okay, so again in these trauma also the same thing happens. What was caused by the enzymes can be also be caused by the trauma. So the enzymes here, either the enzymes or trauma can break the triglycerides to form free fatty acids, can cause free fatty acids, and this is called as, will lead to saponification, and saponification is a good way to see whether the area has undergone fatty necrosis or not. Can you guess what type of necrosis this should be? Because it's a trauma to the adipocytes, this would be what? Liquefactive. Remember the fat cells of the brain also? It will be liquefactive necrosis. Now this you could have guessed because you are told that the brain also undergoes liquefactive necrosis. The brain also undergoes liquefactive necrosis. This is the fatty necrosis. Okay, let's see the image once. You will understand this better. Now this is the chalky white deposit of the mesenteries. This is the chalky white. Look at this chalky white. I'm drawing this with yellow color or green color better. This is the chalky white. These all are the chalky white deposits. So in the microscopy, they won't show you granuloma. So don't confuse this with caseous, because in microscopy, it will show you this type of completely necrosed fat cells. Completely necrosed fat cells. It's called as fatty necrosis. Now, this should appear pink in color. But what is happening? Because this pink color is combining with the calcium with the necrosis, and therefore it is appearing basically blue. This should have appeared pink because it's necrosis, but because of the calcium here, the whole thing is appearing blue. But don't confuse. What is more important to look at these completely liquefied tissue. Look at the completely liquefied tissue. How does a normal fat cell look like? This is how the normal fat cell look like. These are all are adipocytes. I'm writing A here. These all white cells you are seeing are all the fat cells or the adipocytes. These all are adipocytes. Now compare this image to this image. देख रहे हो? Completely liquefied mass. Completely liquefied mass. It's called as fatty necrosis. Fatty necrosis. Okay. Finally, we move to the next type. Next type, that is fibrinoid necrosis. Okay. Fibrinoid necrosis. What is this? Remember, it again is not a type of necrosis. It is fibrinoid, like fibrin. Okay, it's a fibrin like morphology. It's a fibrin like morphology, not the necrosis at all. It's a fibrin like morphology. The question is, what is fibrin like morphology? What is this? Fibrin like morphology refers to a homogeneous pink color. It refers to a homogeneous pink color. It is called as fibrinoid necrosis. Homogeneous pink color. The site of this is seen in vessels usually, and the etiology of this would be, see, it will be damage of vessels due to damage of vessels due to what will damage a vessel to cause homogeneous pink deposit. The answer is either inflammation of vessels called as vasculitis, either inflammation of vessels like vasculitis, or very high blood pressure called as malignant hypertension, or there can be immune complex deposition, which we have read as antigen and antibody complex are called as immune complex deposition. So again I repeat, it happens in vessels. It happens because the vessels have been destroyed due to either of the three reasons. Maybe inflammation, so called as vessel inflammation, vasculitis. Maybe very high blood pressure, very high BP. Okay, BP is very, very, very high. So malignant hypertension or immune complex deposition. So what happens if this is a vessel here? You will see the pinkish necrosis here. As it is called as fibrinoid necrosis. It's called as fibrinoid necrosis. Okay. Let's see this image again. This is a vessel, right? It's a lumen. It's a lumen here. It's called as fibrinoid necrosis. This is the fibrinoid necrosis. See, what you are seeing here is, look at this vessel. This is a lumen of the vessel. Why? Because they have RBCs here. Look at the RBCs here. This red one is RBC. And look at this pinkish color, all pinkish color deposits here. देखो ये आता ये वाला ठीक है. One more image. Look, this is a vessel. This is a thrombus in the vessel. So just ignore this thrombus and look at this here. Sorry. This whole pink area here is the whole pink area here from here. This all is the homogeneous pink deposits and hence referred to as fibrinoid and the fibrin like. Actually, in histopathology, the fibrin appears homogeneous pink and this vessel is also appearing homogeneous pink in its wall and hence the term we use for this is fibrinoid. Fibrin ke tarah, like fibrin. Like fibrin. It's all about the fibrinoid necrosis. So eventually, if you look at this necrosis, a 2-minute revision see. First of all, understand coagulative. Whenever you see a cell outline preserved, it's coagulative. Color is pink. Why it is pink? Because of protein damage. Why is the blue color reduced? Because of nucleus damage. Nucleus appears blue. Because the nucleus is damaged, the blue will not appear. So decrease basophilia and increase eosinophilia. Okay. Whenever you see an image like this, when you don't see any outline, liquefactive necrosis. If you see an area having completely lost the blood supply and this area is neither being removed by the neutrophils nor oxygen, it undergoes anaerobic decomposition. It causes dry gangrene. If this gangrene has a superimposed bacterial infection, it causes wet gangrene. It causes wet gangrene. This is gaseous necrosis. This is the cheesy white deposits here. And what you see in microscopy is a granuloma with a giant cell. Granuloma with a giant cell. You may see fatty necrosis in which the whole tissue appears liquefied, and on the gross morphology you see chalky white deposits. And finally we move to the necrosis where you see fibrin like deposits on the vessels. It is called as fibrinoid necrosis. It's called as fibrinoid necrosis. So in doubt? Okay, sir, I did not understand how basophilia decreases. देखो बेटा, basophilia is due to blue color. And why is there blue color? I have written here. The blue color is because of usually the nucleus. So, because of the dissolution of the nucleus, the blue color will not be seen and hence decreased basophilia. Why blue color decreases? I told you, because of the decreased basophilia. And why is the decreased basophilia happening? Because the nucleus, which was originally staining blue in color, is no longer there. क्यों? Karyolysis, lysis of the nucleus is there. ठीक है? Repeat wet gangrene. चलो देखो wet gangrene क्या है? If ever you see a dry gangrene, which is a coagulative necrosis, and on this there is a bacteria infection, and bacteria has released all the enzymes. So all the cell outline which was preserved in the dry gangrene is removed in wet gangrene, and hence it is again a liquefactive necrosis. Could you please repeat the cell outline difference in coagulative and liquefactive? Okay, good question. देखो, if you see the cell outline intact, मतलब देखो what I'm trying to say. Let's assume you don't see this image. You only see this image. देखो, this one is one outline. Okay, and inside this you are seeing pink color. Inside this you are seeing pink color. ऐसे. And I am saying drawing one more image like this. ऐसे. ठीक है? Let's call this A and let's call this B. Tell me among them which is coagulative. Tell me among them which is coagulative, A or B. I think then you will understand it. Again the comparison between enzymatic and traumatic. Please explain. Comparison कुछ नहीं है. It's not a comparison. It's a type of damage. देखो. If you look here, either the enzyme or trauma. Either enzyme or trauma can damage the adipocytes and will cause free fatty acids. So either trauma or the fats, or either trauma or the enzymes, they will cause the same effect. The damaged adipocytes to cause the free fatty acids. Why does pH decrease in coagulative necrosis? आप बोलो, देखो यहाँ पर, just like in reversible injury, we have seen that increase in lactic acid occur. Why was increased lactic acid occurring? Because of anaerobic glycolysis. Because of the anaerobic glycolysis, there is increased lactic acid, so pH decreases. And decrease in pH is acidification, so it will inactivate the enzyme. Now, this increased lactic acid was occurring in reversible injury. Why? Because of anaerobic glycolysis. You see, the anaerobic glycolysis will also occur in irreversible injury, isn't it? So that means the amount of decreased pH will be more in irreversible compared to reversible, and therefore the same effect is there. So, what is the answer for this question? ये बताओ कहाँ गया? Yeah. Which of them is coagulative? A is coagulative and B is liquefactive. A is coagulative and B is liquefactive necrosis. Fibrinoid necrosis is coagulative or liquefactive? Fibrinoid is not a necrosis. Fibrinoid is not a necrosis. So let's move ahead now. We'll move to the next disease, and this I think it will take a lot of time. So this will be the last topic of the day, and it would be apoptosis. Okay, we'll take one more topic today. Again, it's very important for your MCQ point of view also. It should be apoptosis. Okay, we move to the next topic of apoptosis. We all know there is a very common name for this. It's called as programmed cell death. Okay, it's called as programmed cell death. Okay, apoptosis is called as programmed cell death, means like necrosis was a death due to pathological effects. So we don't have control on that. We can't control the pathological effects. It's death by chance. But this is a programming done to actually effectivize, to actually cause a cell death. That means the tissue is programming something to cause a cell. It's a deliberate killing of a cell. It's a deliberate killing of a cell. Okay, it's a deliberate killing of a cell. Okay, so it involves the activation of some enzymes. It involves activation of intrinsic enzymes by a programming in cells. ठीक है, to form fragmented cells called apoptotic bodies. To form fragmented cells called as apoptotic bodies. Okay, and finally we'll see that these bodies are engulfed by macrophages. They're engulfed by macrophages. Okay, they are then engulfed by the macrophages. Okay, to understand this topic better, let's start with what are the causes of apoptosis. This will make your understanding better. Causes. Apoptosis can be physiological as well as pathological. Let's start with the physiological examples. First one, it occurs during embryogenesis. It occurs during embryogenesis. And because you understand better, you just read anatomy and embryology. In embryology, you talked about implantation, you talked about organogenesis, you talked about the metamorphosis. Now, all the cells during the developmental process are destroyed by a programmed cell death called as apoptosis. Programmed cell death called as apoptosis. That means any tissue during development which is not required. So cells during organogenesis, for example, about the notochord. Notochord is not actually important in the human morphology, and therefore they all are removed by such organogenesis, are I should say destroyed by apoptosis. Okay, by apoptosis. Okay. Second, it also by the hormonal withdrawal. For example, you all know that after every cycle of menstruation, the endometrial lining is shed out. Those endometrial lining is shed out and finally removed by apoptosis. That means the endometrial cell breakdown after, or you say, in menstrual cycle or in menopause. These all breakdown will occur by the programmed cell death called as apoptosis. Okay? Next, you all know that there is a requirement to remove the self-reactive lymphocytes. That means you heard about in physiology, you might have read about, or in biochemistry in the immune system, immunology, you might have read about, there's a need to remove the self-reactive lymphocytes called as central tolerance. So, removal of self-reactive lymphocytes, in thymus. This is called as central tolerance and is also done by apoptosis. Okay, apoptosis. Finally, you all are aware that in inflammation or any infection, the WBC count increases. You all know WBC count is 11,000, 4,000 to 11,000. And then you also know that during inflammation, the count goes to say 20,000 or 30,000 or 40,000. So that excess WBC, after the inflammation is over, where do they go? Do they go back to bone marrow? No, they all are removed by apoptosis. That means post-inflammatory response, the excess inflammatory cells are removed by apoptosis. So four main causes. One of them is during embryogenesis. Next is in hormone withdrawal. Next is removal of self-reactive lymphocytes in the thymus. Fourth is post-inflammatory response. That means excess inflammatory cells like WBCs are removed by apoptosis. Okay, but the question is, does it occur also in pathological situations? Definitely yes. Let's see those. Now we'll see the pathological causes. One of them is the DNA damage by either a radiation therapy, or chemotherapy. Okay, radiation therapy or a chemotherapy or hypoxia. So all of these DNA damage are removed by apoptosis. Okay, apoptosis. Second, it is due to accumulation of misfolded proteins. Accumulation of misfolded proteins. So as you all know, the misfolded proteins are removed by the ubiquitin pathways. So they are effectively done by apoptosis. Okay. Finally, there are some cell death in infections. Especially the viral infections, like HIV or the hepatitis virus. Similarly, it also is seen in the parenchymal death. It is seen in some of the organ cell death if the organs ducts have been blocked by a stone or something. That means it is due to it is in the organs, in some organs, in organs due to duct obstruction. Okay, due to duct obstruction. Okay, and which organs? Mostly the parotids or pancreas can be there. Okay, example, the parotid ducts, parotid glands, or in the pancreatic glands, pancreas. Okay, so if these ducts are actually obstructed by the stones, so what happens? Our body tries to destroy the organs, the organ per se, by the process of apoptosis, by the process of apoptosis. Now, obviously, these are pathological events. I'm not saying they're physiological; they are pathological effects. So, all of these are examples of apoptosis. Let me read this again. Pathological causes like DNA damage, accumulation of the misfolded proteins, cell death in infections, especially the viral infections like hepatitis and HIV, and in organs due to duct obstruction, example parotids and the pancreas. Parotids and the pancreas. Okay? We'll now move to the mechanism of apoptosis. Okay, there are some doubts. I'll just see that. If ischemia causes coagulative necrosis, then how does the neutrophil reaching the site? अरे देखो, ischemia is due to the partial obstruction of a vessel. ठीक है? And therefore, through the partially obstructed vessel, neutrophils can reach there. In fact, neutrophils are also in a tissue. But imagine a case of gangrene where there's a complete, four times complete बोला है, complete obstruction of the vessels, because of which even the neutrophils cannot reach there. And in fact, yes, they're not end arteries. Very good. They're not end arteries. If fibrinoid is not a necrosis, then why it is called a necrosis? Well answered also below. It is not. It is due to the anti-antibody complex and is not due to the ischemia. Okay, why it is called necrosis? Because it looks homogeneous pink, and people and pathologists have confused this with necrosis. Necrosis appears pink homogeneous, fibrin appears pink homogeneous, so they thought it is necrosis, looking like fibrin, named it fibrinoid necrosis. Then they realized गलती हो गया. But एक बार बच्चे का नाम रख दिया, एक बार, once you have named a baby, for example, you have named a baby Modi, and the Modi becomes Prime Minister. Now you cannot change him. It's Modi now. Okay. Mechanism of apoptosis. So there are two pathways, guys. There are two pathways that you should all be aware of. Two pathways. It is intrinsic pathway. Okay, intrinsic pathway, also called as mitochondrial pathway. Okay, and B, it's extrinsic pathway, also called as death receptor pathway, also called as death receptor pathway. Death means the FAS, that's right, for accurate, right? Death or the FAS receptor pathway. I'll talk about this separately also. Okay, death receptor pathway. Now understand one thing. The intrinsic pathway, also called as mitochondrial pathway, is a type of cell suicide. It's a type of cell suicide. It's a programmed cell suicide. Okay, but extrinsic is a programmed murder. It's a programmed cell murder. How does the process occur? We'll see that in a diagram. Okay, we'll see that in a diagram. What we'll do is we'll try to make a pathway for both intrinsic, extrinsic. Remember, it's a big pathway, so it may become a bit, haphazard while you draw it. So what to do is, after you've drawn this, if it is not very clear, try to again redraw this and stick in front of a study table, because this is a very, very important diagram we're going to make now. Divide your entire page into two pathways: intrinsic on the left side and extrinsic on the right side. Intrinsic and extrinsic. Okay. Now see, because of any sort of cell injury, like it can be a growth factor withdrawal, growth factor withdrawal. Okay, it can be radiation therapy, radiation damage. It can be protein misfolding, as I told you, protein misfolding. All of these will lead to intrinsic pathway of apoptosis. It's a very long pathway to have some space for it. However, the extrinsic pathway, it usually occurs because of Fas and Fas ligand. Okay, this occurs because of a Fas. I'll talk about the Fas separately also. The Fas acting on the Fas interacting, Fas interacting with the Fas ligand. Now, what is Fas? Fas stands for, the full form is first apoptotic signal. It basically is a tumor necrosis factor receptor, TNF receptor, whereas Fas ligand is a tumor necrosis factor. Okay, the Fas is a TNF receptor, also called as CD95, also called as CD95. So this is called as TNF receptor or the Fas, which interacts with the Fas ligand, that is TNF. Okay, now we'll talk about this separately also. Let's move ahead first. देखो क्या होता है? The cell injury, this whole cell injury, it is first, this is one thing and this is other thing. Okay, the cell injury, it is first sensed by molecules called as apoptotic sensors. Apoptotic sensors. The apoptotic sensors are actually a family of molecules which belong to the BH3 only proteins. They belong to the protein called as BH3 only proteins. Now, what is BH3 only proteins? BH3 only protein, please understand that whichever proteins we are going to write in apoptosis, they have a BH domain. Please, let's write it here. There's a BH domain protein. And actually, there are 4 BH domain proteins. There are 4. That means, as it's written, it's not very good. The BH domain proteins are having 4 domains. They actually have 4 domains. 4 domains. Okay. Now, some molecules have all the 4 domain. Some molecule have one of the 4 domain. And some molecules have one or more than one domain. So, some proteins are called as BH3 only domain, which means that they have the third of the 4 domain. They are the third of the 4. What is domain? Domain is a structure like A, B, C, D. Domain A, domain B, domain C, domain D. Some proteins have all the 4 domain. So we'll call it BH domain protein. Some of them have only the third domain, like the third one, this one. We'll call it BH3 only domain. BH3 only protein. Okay, this is how they are named. So the BH3 only protein means they have the third domain only. Example of the proteins are very funny names. Example are BIM BIM, BID BID, BAD BAD, BIM BID BAD, Noxa and Puma. Noxa and Puma. Okay, so what happens? The BH3 only proteins, this one, they actually have BIM BID BAD, Noxa and Puma are the examples of the BH3 only proteins. Now, what these proteins do is they sense that whether the injury above is severe or not. Okay, if they are sensing that yes, the injury is severe, okay, if they are sensing that they have severe, they have basically severe injury, so what they will do is they will activate the pro-apoptotic proteins. They will activate what? They will activate the pro-apoptotic proteins. However, if they feel that the injury is not of very severe nature, they will decrease the pro-apoptotic and increase the anti-apoptotic protein. They will increase the anti-apoptotic proteins. So what I'm trying to say is, let's assume that the injury is very severe. Once the injury is very severe, they're sensed by BH3 only proteins, which are BIM BID BAD Noxa Puma. Once they are sensing it, what they do is these what will do is they'll do two things. On one side, they will increase the pro-apoptotic proteins, pro-apoptotic genes, you can say, or and the proteins, and decrease the anti-apoptotic genes. And genes obviously will code for proteins. The genes will obviously code for the proteins. The genes will code for proteins. ठीक है? अच्छा. What are the examples of pro-apoptotic genes or the proteins? The pro genes are BAK and BAX. So these will increase. While what are the examples of anti? They are BCL1, BCL2, BCLXL and MCL1. So all of them will decrease. Okay. Now how to remember this? देखो, any gene with letter L. Remember, any gene with letter L, L का mnemonic है long life. It's not a short full form. It is a mnemonic. That means any gene with letter L will be anti-apoptotic. देखो, apoptotic is cell death. So any gene which is having a letter L will be actually anti-apoptotic. L से long life याद कर लो. From L, just remember it is long life. L से remember it is long life. ठीक है? From L, remember it is long life. Okay. Also remember the pro-apoptotic genes which are back and backs, they basically have the first three BS protein. Okay, these have the three. They have three BH domain. Now don't confuse this with this term which has a third domain. That means they have only one BH domain. They have only one BH domain. So sensors have only one BH domain, while the pro-apoptotic genes have the three BH domain. They have the three BH domain. In fact, the anti-genes have all four BH domain. The anti-genes have all four BH domain. I'm going slow. Don't worry. These are confusing, but it will be very, very fruitful for you. ठीक है? Now देखो. Once these genes have sensed that there is a definite need for apoptosis, what they do is all these genes will start acting on the mitochondria. These genes will all act on the mitochondria. Okay, these two will act on the mitochondria. Okay, now suppose there's a mitochondria. Mitochondria, if you remember, has an outer and an inner membrane. Normally, the permeability of the outer membrane is impermeable. Normally, the outer membrane is impermeable. But what do these genes do is they try to increase the permeability here. So the permeability is increased here like this or like this. So because of the permeability getting increased, a protein called as cytochrome C, they start leaking out. It comes out. What comes out are these proteins called as cytochrome C. They come out as cytochrome C. Once cytochrome C comes out, they start activating a unique protein called as caspases. Okay, so once cytochrome C comes out, this cytochrome C, they activate a enzyme called as caspases. They activate the enzyme called as caspases. Okay, they activate this enzyme called as caspases. Okay, write it down. They activate the enzyme called as caspases. In fact, when you look at the other pathway we are writing here, you first complete this and then talk about the other pathways. You first complete this. The pro genes which have increased, the anti genes have decreased. The end result is cytochrome C comes out of the mitochondria. So if you ask me, sir, where is cytochrome C normally present? Normally it is I hope you remember the F0 F1 complex is in the inner membrane. Yes, the cytochrome C is the same cytochrome you have read for the electron transport chain in the biochemistry. That cytochrome can also cause apoptosis if it comes out into cytoplasm. If it comes out into cytoplasm, the same cytochrome C of electron transport chain can lead to apoptosis. अब देखो क्या होता है. On the other side, here we are writing extrinsic pathway. So extrinsic pathway में the fast ligand it interacts with the fast molecule. Then what happens? They then activate a molecule called as FAD. The FAD stands for fast associated death domain. they activate something called as fast associated death domain. And actually, this will then again activate the caspase. Just like in the intrinsic pathway, they also activate caspase. The difference is this activates caspase number 8, while this one activates caspase number 9. Now, how to remember? Very simple to remember. See, EIGST8 and extrinsic. So, E and E. Okay. Now, what I'm trying to say here is the extrinsic pathway has activated caspase number 8. The intrinsic has activated the caspase number 9. The caspase number 9. Okay. Now what happens? Either there is caspase number 8 or there is caspase number 9. These caspases are called as initiator caspase. Okay. These caspases are called as initiator caspase. This one. Initiator caspase and initiator caspase. So 8 and 9 are examples of initiator caspase. Once this happens, this 8 and this 9, the 8 and 9 will now, this 8 here and the 9 here, they will now together, they'll now activate the executioner caspase. The executioner caspase is caspase number 3 and 6, both of them. Caspase 3 and 6 are the examples of executioner caspase. Now what happens? Because of the activation of the executioner caspase, what they do is they cause endonuclease activation, and they also cause cytoskeletal, मतलब protein breakdown. So two things are broken down. One is the endonucleus of the nucleus and one is the cytoskeletal, that is the plasma membrane. That is a plasma membrane. Okay, that is a plasma membrane. So before I move forward, I'll just repeat this again so that you don't confuse yourself. So take a deep breath and just revise with me. देखो क्या हो रहा है. We're discussing two different pathways, intrinsic and extrinsic. Actually, if you see, both of the pathways have the same aim. Ultimately, both the pathway want to activate what? They want to activate executioner caspase. But the way to activate is different. In the intrinsic pathway, it is the body cell molecules which are actually recognizing whether there is a need of causing apoptosis or not. So the cell is self-recognizing that yes, the injury was severe and I need to activate the process of apoptosis. Because the cell is itself activating it, hence it is called as intrinsic pathway. But if you look here it is not the cell which is recognizing and deciding whether there is a need of apoptosis or not. It is the activation of fast and fast ligand which is causing apoptosis. So this is called as extrinsic pathway. I again repeat, this is called as intrinsic pathway because the cell has the ability to decide whether the apoptosis will occur or not. And how it is deciding? By the BH3 only protein. Once the BH3 decides that yes, the injury was severe and I need to cause apoptosis, they will increase the progenes, decrease antigens. Now, if you ask me, sir, what if the injury was not very severe? Opposite. If the injury was not very severe, they will decrease the progenes, increase the antigens, and they should not proceed further. So again repeat, because a cell is deciding whether there is a need of causing apoptosis or not, it is called as intrinsic pathway. Now once this happened, they take out cytochrome C from the mitochondria. This is a mitochondria, right? This is a mitochondria. So mitochondria outer membrane becomes permeable, and therefore what comes out is cytochrome C. In fact, cytochrome C, this cytochrome C, right, it combines with a protein called as APAF1. It combines with a protein called as APAF APAF1. Now this combination is often referred to as apoptosome. This was a question also asked in this year's AIIMS. Apoptosome Apoptosome is a combination of cytochrome C with APAF1. Now, what is APAF1? APAF1 stands for, I'll write the full form here. APAF1, it stands for apoptosis activating factor 1. APAF, APAF1. So, the APAF1 activates the initiator caspase 9, which then activates the execution caspase 3 and 6. Now let's see the extrinsic pathway. Here the fast ligand acts on the fast ligand क्या है? Tumor necrosis factor. Acts on tumor necrosis factor receptor, also called as C95. This action activates FAD. What is FAD? Fast associated dead domain, and this activates caspase number 8. The caspase 8 will then activate caspase number 9. Sorry, caspase number 3 and 6. 3 and 6 is therefore called as execution caspase. Finally, this caspase will cause activation of two things: endonuclease activation and the cytoskeleton protein breakdown. Now see, if you see these all things in a cell, what has happened till now? Dekho, what will these two, let's complete this whole thing. This two will lead to formation of apoptotic body. Now, what is apoptotic body? Apoptotic body is a cytoplasmic bleb with the organelles and the nuclear fragmentation and the fragments of nuclear. So nuclear fragments and the nuclear fragments. Okay. Then what happens? The apoptotic body, it will be released out. Okay. Apoptotic body, this is the AB. It separates out from the main cell, and finally it is engulfed and removed by macrophage. Engulfed and removed by the macrophages. Now this completes the process of apoptosis. This will complete the process of apoptosis. Okay. Maybe some things are not clear, but don't worry, I'll explain to you again and again this, because I know it's not very simple. So let's try to explain this again and again. Dekho, what is happening now? If I try to explain this whole thing in a diagrammatic view, let's understand what is happening there. Let's assume there's a cell here. Okay, this is a cell. Okay, now I have cut the cell into half. Okay, let's assume here there is a cell injury. Okay, and here there's action by the Fas ligand acting on the Fas. So this becomes what? Intrinsic pathway, and this becomes what? Extrinsic pathway. Agreed? Now the cell injury will first be sensed by BH3 only proteins. Okay? The BH3 only protein, like the BIM, BID, BAD, NOX and PUMA, what it will do is it will increase the progenes and decrease the antigenes. The combined action of these two will act on the mitochondria. Let me draw the mitochondria with blue color. And from the mitochondria, the cytochrome C will come out. It comes out. This will then combine with APAF. Okay, and this two, called as apoptosome, will then activate what? Caspase. Which one? Number 9. The Fas and Fas ligand, it will activate what? Caspase number 8. This 9 or this 8 will then activate what? Execution caspase number 3 and 6. Caspase number 3 and 6. Okay. अब देखो what will happen. The caspase 3 and 6 is the executioner caspase, right? Okay. It is the executioner caspase. So what will happen? What will happen is, देखो, actually the caspase 3 and 6, this will do two things. It will on one side break the cytoskeleton. Okay. Cytoskeletal breakdown. And on one side they'll cause nuclear breakdown. Now suppose there's a nucleus here. This is the nucleus of the cell. It will break the nucleus. I'm writing what? Endonuclease breakdown. Endonuclease breakdown. Because of which, what is happening is, this is very important now. From the main cell, a pinched out product will appear like this. Essay. From the main cell, a bleb will come out like this. Essay. The cell is putting out a bleb. Now you may ask me, sir, what are the reason of the bleb? What is the reason the bleb is coming out? What does the bleb do? You might ask me, sir, what does a bleb do? The bleb has a condensed chromatin here, ऐसे, very condensed chromatin, and has various organelles here. In fact, this bleb has a condensed broken chromatin, but all of them are condensed. Okay, they have the chromatin which basically has come from the nuclear fragmentation. So if this nucleus has fragmented here, the nucleus is fragmented here, it is coming in the form of this fragments of nucleus like this. Okay, so what are these? These are nuclear fragments. These are nuclear fragments, and these are the organelles. These are the organelles. Okay, now see what happens. This is being called as apoptotic body, right? This is being called as apoptotic body. This apoptotic body will then separate out. Look at it, separate out like this. Okay, it has separated out, which has the nuclear fragments and has also various organelles like this. Various organelles like mitochondria, ER, whatever has got damaged, it is coming out. Now see what happens. This will be then engulfed by macrophage. It is now, this is the again apoptotic body. This apoptotic body is then engulfed by the macrophage. So this is a macrophage, guys. Ye macrophage hai. Okay, the macrophage will engulf. Okay, it will engulf the apoptotic body. The macrophage will engulf the apoptotic body. Yes, there is a sensing involved here. I'll talk about sensing later on. First, to understand the basic thing. There are some sensors to actually sense which is the apoptotic body, but this sensing I'll talk about later on. First, to understand how the whole event has occurred, how the entire event has occurred. Now, I know that your question would be, sir, why is the reason? What is the reason there is a formation of apoptotic body? Let's see. Dekho, suppose this pen, the refill is not working. Okay. So what I will do? Either I can throw this pen or I can change the refill. But do you think if the pen is not working, I should destroy the entire room here? Just because this pen is not working doesn't mean I should destroy the entire room. Imagine now, the pen is what was damaged by the cell injury. This is the pen here. This pen was damaged by the cell injury. So does the cell need to destroy the entire cell? No. If this pen, that means some of the organelles was destroyed by the cell injury, the cell will program itself in such a way that only the pen, that is few organelles, are destroyed. So actually the cell is programming in such a way that those organelles getting destroyed is put out in the apoptotic body. So these organelles were destroyed by the cell injury signal. That means this apoptotic body is like a dustbin. Suppose this room is a cell and in the room there's a dustbin. If I don't need the pen, I'll throw the pen in the dustbin. So what I've done, this pen, I've thrown it here in the dustbin. Now, next day, this dustbin will be taken out and put in the garbage. Do I need to put the entire room in the garbage? No. Simple logic, right? So this apoptotic body is a dustbin now. It separates out and someone is removing the dustbin tomorrow. The same thing is happening in a cell. And this beautifully explained apoptotic programmed cell death is the way how a cell gets rid of any content which it does not require. Any content which it does not require by forming this body called as apoptotic body. Now the question is, sir, something we have understood, agreed. But tell me, how will a macrophage get to know that this is a dustbin? When the dustbin goes out, How will that person who is taking out the dustbin and we know that yes, this dustbin has to be removed and not this cell? Because ultimately, this apoptotic body also has a nucleus and also has an organelle. So this sensing is here, this sensing. The sensing is actually called as eat me signal. Just make a star mark here. Just make a star mark here and write it is called as eat me signal. What is this eat me signal? Eat me signal comes from the flipping out of phosphatidyl serine. The flipping out occurs from something called as phosphatidyl serine. So what is this phosphatidyl serine? Basically, the phosphatidyl serine is actually in the inner membrane. So when the apoptotic body forms out, this phosphatidyl serine, which is in the inner membrane, it will flip out to the outer membrane. It comes out to the outer membrane like here. Normally it is in the inner membrane. From inner membrane, it comes out to the outer membrane. It comes out to the outer membrane. So when this comes out, this actually is sensed by, the phagocytic, that is macrophage receptors, and hence it is called as flipping out of phosphatidyl serine. Flipping out of phosphatidyl serine. Okay. Remember one thing, the apoptotic body can also be coated by antibodies. They can be coated by the antibodies. Okay, they can be coated by the antibodies. Okay, and then engulfed by the macrophage, So not only this eat me signal works, also by the action of these antibodies, they can be removed. The two ways they are removed. One is by the eat me signal, first way, and second way are by coating by the antibodies. The two way how the apoptotic bodies are removed. Okay. In fact, some of them can also be coated by thrombospondin. One of them is antibodies, guys, and one of them is also thrombospondin. I'm just not going to detail of this. It may confuse you, but write it thrombospondin. So all these molecules like thrombospondin, antibodies, they can coat the apoptotic body so that they can easily be removed from the body. They can easily be removed by the body. Okay? They're called as eat me signal. It's called as eat me signal. But this diagram, you must remember to understand the basic concepts as to what is happening in the apoptosis. Now, again, I tell you guys, if you read this from Robbins, this whole thing has been described in at least 3 to 4 pages. When you read that, every line will make a lot of sense to you now. Because now what I've done is I've written this whole big paragraph into a flow diagram, and that is what a faculty is for. What we will do throughout the year is we'll try to take out the difficult topics of the entire subject and try to put in a flow diagram. Because now, even though this appears a bit clustered, but once you take this image, look at this one, then look at what are they activating, go by the flow, and then you see they are activating caspase 3 and 6, and then you see they're actually activating caspase and nuclease and the cytosine protein. It will make a lot of sense to you. So let's see this. Okay, I'll show you that later on, that how does this exactly occur. But this is the diagram you'll see in the textbooks as to this is the main cell and this is the bleb formation. This bleb is called as apoptotic body. The bleb separates out. It is recognized by the macrophage by the flipping out of phosphatidyl serine, or by coating by antibodies, or by coating by thrombospondin, which makes this very tasty to the macrophage, and the macrophage can easily engulf and remove this entire apoptotic body. Okay, this is how the process of apoptosis occurs. Now, before we end it, let's understand what is the basic difference between necrosis and apoptosis. What is the basic difference between necrosis and apoptosis? See, first of all, the first difference you should understand between necrosis versus apoptosis. The first difference is necrosis is pathological. Apoptosis is physiological more than pathological. Second, if you look at the morphology, First of all, if you look at the cell size, please understand, necrosis always starts with reversible injury. That means before the cell is undergoing necrosis, there should be cell swelling, right? There should be cell swelling. Okay, there should be a cell swelling. Okay. Now, in apoptosis, you'll see cell shrinkage. Now, why cell shrinkage? Because the apoptotic body is smaller than the main cell. Apoptotic body is smaller than the main cell and hence it is cell shrinkage. Then the chromatin. The chromatin in necrosis first underwent pycnosis, then underwent karyorrhexis, and then underwent karyolysis. But if you see in apoptosis, there's only and only pycnosis, nothing else. Pycnosis only, nothing else. Now, if you look at the cell outline, that is the cell membrane, you can see the plasma membrane. In necrosis, it was broken. It is disintegrated. Even though it is maintained in quality, but it is broken, right? But in the apoptosis, it's intact. You see, apoptotic body never broke its outline. It is completely intact, right? Then you see neutrophils. Neutrophils, that is acute inflammation was present in apoptosis. It is absent in, it was present in necrosis, is absent in the apoptosis. Okay, again, a very, very important way to differentiate necrosis versus apoptosis. So these are the basic differences between these two steps. Again, remember, necrosis had a cell size increasing, apoptosis mein cell shrinkage. Why? Look at the apoptotic body. Then chromatin in necrosis underwent 3 steps. First pycnosis, then rhexis, and finally karyolysis. But this had undergone only and only pycnosis. Cell outline was broken in necrosis, because of which the lysosomal enzymes came out and that caused inflammation. But here what you see, this is completely intact and you don't see any inflammation here. So based on these facts, can you recognize necrosis versus apoptosis? Let's try this. Let's try, guys. Look at this cell. In this image, what you're noticing is this whole thing is a tissue. This is a tissue. And look at this cell here. What you're seeing is this is an apoptotic body. Okay. Now notice the apoptotic body here. Notice here. This apoptotic body, it has a maintained outline. Completely maintained outline. Okay. So outline, don't write. First understand. Outline is maintained, not broken. Okay. Outline is maintained. Size is shrunken. Neutrophil inflammation is absent. And more importantly, look at the center. Complete center here. This center is showing you the blue color. This blue color means chromatin has condensed here. There is chromatin has condensed. So 1, 2, 3, and 4. This is what makes a apoptotic cell mainly different from necrosis. Had this been necrosis, what you would have found? If this would have been necrosis, I was drawing it here, you would have found a pinkish color here, as a pink color here. You would have found various neutrophils coming out here, as a inflammation, and you won't have found any nucleus. Chromatin is completely lost. Cell outline disturbed. inflammation present, chromatin absent, neutrophils present, inflammation present. So cell size increased. So when you compare this is necrosis and this apoptosis, nothing should be as simple as you like this. So now what is the take home message here? Necrosis and apoptosis are vastly different process. Even though they both are for cell death, the process is different, the reason is different, and more importantly, the morphology is very, very different in both of them. So it was a long session, but I think it had cleared a lot of things. I don't know how many of you are even online. It's already 9:20. So I don't know. Can you tell me how many of you are actually interested in watching the video? I can't see you, but how many of actually have left, because that is a commitment actually misses in second year, I'm telling you. But if you are watching the video till now, I think you are one of the winners, because many of the students, they would try to watch but they won't watch completely. But if you are one of those who have tried to watch this complete video, you are one of the winners. And when you watch this video or understand the topic by reading the textbook again, the whole concept will flow like a fluid. I'm very sure out of it. So are you available there or you have left? I don't know. Please let me know. So this is what is called as apoptosis. So there might be a few doubts in your mind. Don't worry. What you do is read all of this again, and this thing especially, this flow diagram especially. Okay. If this flow diagram was not very clear while you're drawing, try to draw it again and stick in front of a study table. Believe me, this is a very, very confusing topic. So wonderful to see you, because it's quite early in the class, and I think these topics should make a tone out of it. It should actually build your knowledge, and it should help you to sit on the study table watching the videos. Okay, because this is a new normal life, and you have to learn the art of seeing a video and making your own notes, and at the same time trying not to get distracted from what is happening around you. Okay. Coating of the antibody by antibodies called opsonization. Yes, sir. Nice is ordinary. Okay. So suppose you have done very extremely good, and someone calls you nice. Nice is very ordinary. Okay. So it's okay. I keep on saying these things just to keep cheering you up.